Now, I would request Dr. Sagnik Mukherjee, consultant at Monipal Hospital, to present the rehabilitation care for the movement disorders.
Thank you, respected chairpersons and Professor Shomar sir. My presentation is on the role of rehabilitation medicine in the management of movement disorders. So here we have an elderly patient. This is the patient before treatment and after treatment. And our question is, how did the patient progress from this condition to this condition? The answer lies in rehabilitation. Rehabilitation for neurologic disorders, including movement disorders, has been evolving over the past few decades, as these patients often have motor control deficits in part because of the neuroanatomic overlay. This is a model of the direct and indirect effects of the movement disorders and their consequences on the key functions with the suggested goals of therapy and therapeutic approaches like a structured exercise program to prevent or reduce impairments, gait training, balance trainings, all of which will be discussed in the next slides. The key frameworks which guide neurologic rehabilitation for those with movement disorders are based on the principles of neuroplasticity and motor learning. The two types of brain plasticity, the structural plasticity and the functional plasticity. Structural plasticity deals with experiences or memories which changes a brain's physical structure, and in functional plasticity, the brain functions migrate from a damaged area to an undamaged area. The main objectives of neurologic rehabilitation for individuals with movement disorders are to maintain the body structure and to maximize the functional skills. Maintaining body structure optimizes the potential for performance in the day-to-day life and minimizes secondary medical complications, for example, pressure ulcers caused by posturing in spastic dystonia, etc. Maximizing functional skills facilitates functional independence, the quality of life, and a decrease in the burden for the caregiver too. Rehabilitation for individuals with movement disorders can be viewed through two lenses: a restoration of the normal movement and a compensation for the impairments and functional limitations resulting from the movement disorder. This involves use of task-specific training, repetition, intensity, and salience, which is applied to physical rehabilitation. So we'll move on to the targets of physiatric intervention, that is gait training, range of motion, skin integrity, cardiovascular fitness, and balance restoration. Moving on to the first target, that is gait training. These are the various rehabilitation equipments to achieve gait training like rolling walker, platform walker, body weight supported treadmill, harness systems, and orthotic braces. Individuals with movement disorders are at an increased risk of falling because of their balance deficits. Gait and balance training to reduce fall risk is always recommended for patients with movement disorders. And the advantages of this are improved endurance, improved balance and coordination, improved strength, motor planning, and improved confidence. Intensive ambulation training should be used, which may be achieved using the safety harnesses, body weight support systems, assistive devices, bracing, or a combination of all these strategies. For individuals who are unable to walk, static upright activities such as supportive standing should be initiated, addressing the various domains of body structures like force production, motor control, cardiovascular fitness, and contribution to the progression to more dynamic upright activities like ambulation. Moving on to the next target, the range of motion. This employs equipments like serial casting, splints, range of motion exercises, optimal positioning, and chemodenervation. This slide shows the gradual improvement over time in a patient's foot with serial casting. As already discussed by my previous speaker, Shomar sir, the role of botulinum toxins in various movement disorders. I'll not be going into the details of the various disorders. The advantages and disadvantages of various agents like phenol or botulinum toxin. In phenol, the action is non-selective. In botulinum toxin, it's more selective. The onset of activity is immediate with phenol. It's a bit delayed with Botox. The titration of response with phenol is either all or none, but with botulinum toxin, there's a dose-dependent response. Phenol, the duration of action of phenol lasts for around 6 to 18 months, whereas with botulinum toxin, it's around 3 to 6 months. And phenol is often painful to inject. However, with botulinum toxin, the case may not be so. Moving on to the next target of skin integrity. This involves the use of supplemental padding, positional changes. In cases where there's already pressure ulcers have developed, we use laser therapy, and hyperbaric oxygen therapy may be used. This image shows the impact of laser therapy on a patient with pressure ulcer. You can see the difference between the two images just over a period of a month. There's a massive improvement in the ulcer. The next target, cardiovascular fitness. The seated biking, steppers, treadmill training with or without support is often used to improve the cardiovascular fitness of the patients. This shows the seated biking. For balance restoration, we use standing stepping frames, tilt tables, PNF training, the proprioceptive neuromuscular facilitation training, etc. The standard stepping activities improve the outcome in all six F domains, that is the functioning, family, fitness, fun, friends, and futures. This slide is more in response to cerebral palsy patients with movement disorders, especially the children, and these domains help us in integrating the patient into the community at large. This image shows a tilt table which is used for balance training. So how do we determine the frequency, duration, and the setting of care for a patient with movement disorders? Patients may be treated in an inpatient setting if they had a recent or a serious decline in functional performance, or if an inpatient setting is part of a diagnostic workup. Casada et al. Found that individuals with Parkinson's disease benefited from inpatient rehabilitation to minimize decline in the motor function. Patients may also be treated in inpatient setting because of the secondary complications to the movement disorder or because of falling, as found by Gerlach et al. Individuals with a new onset of movement disorder secondary to suppose an acquired brain injury may also warrant inpatient rehab. Factors affecting the length of stay in a rehab unit. The length of stay for the population is highly variable and depends on multiple factors like the extent of deficits, location of lesions, the funding for rehabilitation, the ability of the care partners to provide assistance upon discharge, and availability of other resources like home modifications, equipment acquisition, etc. Patients often require a long-term rehabilitative care, which can include outpatient rehabilitation or home rehabilitation services, which means there is a continuum of rehabilitation from hospital to the home, from acute care, inpatient rehab to home-based therapy, and followed by our ultimate goal, that is community reintegration. Regular follow-up with physiatrists can ensure that the rehabilitation needs are addressed. Education for the individual, family, and care partners regarding information related to the long-term needs, empowering the individual and care partners to advocate for their needs over long term. Therapy team roles. The movement disorders patients benefit from an interdisciplinary approach to treatment. Rehab is always an interdisciplinary field involving the physiatrists, a neurologist or a neurosurgeon or other medical specialties as required, a nutritionist, orthotists, social workers, psychologists, speech pathologists, physiotherapists, occupational therapists, and rehab nurses. Among the team are the doctors, the physiatrists who coordinate with other medical specialties who are involved in the pharmacological and the surgical treatments. And we may also perform chemodenervation as required. We assess the individual before and after the medical interventions such as chemodenervation, the medical trials or surgical procedures as mentioned by sir, the deep brain stimulation, focused ultrasound, etc. We measure the individual's gait speed, on and off medications to assess the effect of the medication on the walking ability of the patient. The other team members, the physiotherapists and the occupational therapists, often commonly coordinate their efforts to provide therapeutic interventions to improve an individual's ability to perform their activities of daily living like dressing, grooming, feeding, bathing, etc. So there are some general rules for exercise prescription, which involves the frequency of exercise, the intensity of the exercise, and the duration of the exercise. Though these are general rules, most of the times these need to be customized according to the patient's needs and the patient's abilities. A speech therapist or a speech language pathologist may work with people with movement disorders to assess and treat the deficits in swallowing, speech, communication, or cognition, often collaborating with physiotherapists and occupational therapists to determine equipment which optimizes the positioning of the individual for swallowing, verbalizing, or accessing alternative communication devices. Psychiatric issues are very common in patients with movement disorders. So, psychiatrists and psychological counselors can offer support to the individual to help adjust to their disability. Patients may also benefit from support groups with peer interactions as a means of building a sense of community. It's very imperative that all members of the interdisciplinary team, in their own capacity, should provide education to the individual and the care partners regarding various topics related to the movement disorders. So, our take home message is that early diagnosis, multidisciplinary care, and tailored rehabilitation are keys to improving the function and quality of life in the patient. The timely intervention can slow progression and enhance independence. Together, we can fight the burden of disease in movement disorders, and our united efforts make every step stronger. These are the references where I'm obtained this. So, what we should remember is that rehabilitation may add years to life, but what it definitely adds is the life to the years. Thank you.
Thank you. Thank you, Dr. Mukherjee,
Thank you, sir.
for finishing so early. It gave us a bit of life, for we are running late a bit. Now, any question from the audience? I have one. Do you think there should be, when we are considering home rehab program, home exercise program for the patients with movement disorders, do we need thinking about any time interval between daily pharmacotherapy and rehab program, exercise program? Is there anything?
Definitely, sir. The effect of the medications should also be taken into consideration when we are planning for the duration when the patient is undergoing the physiotherapeutic interventions or the occupational therapeutic intervention. Especially with the daily medications, patients often there is the effects of the drugs weaning off or weaning on. So it's better when to provide the rehabilitation services to the patient during the day at home, when the patient is more amenable to do the regular exercises. When the first consideration for rehab is when the patient feels comfortable to do the exercises, and that can depend a lot on the daily medications.
Thank you.
Thank you, sir.
Parkinson, there is a terminology called chai tech. You know that thing, the chai tech, how they dance and all these things
Yes,
they
sir.
actually are doing. A lot of works have been done. And the musical cues nowadays they are using. Even the torch, when the patient is gate freezing, if you get a separate type of sensory cues, visual cues, the
cues.
patient starts moving. So this is one of the technology. FOG,
Yes, sir.
that means freezing of gait is one of the. Gait is very, very important in any type of movement disorder.
Yes, sir.
You look at the gait, you can never find a single patient of hyperkinetic movement disorders with obesity. But in case of osteoarthritis or in a patient with some Parkinson disease, you get a huge people. They are getting the metabolic syndrome and they are getting all sorts of problems on joint disease. This is one. Another thing is musculoskeletal problem, low backache. They have come to the low backache. But when you examine the patient, you find that this is a non-metro manifestation of Parkinson's disease. Though a lot of people are being tested with physiotherapy, but if you see whether there is rigidity or not, what is the gait of this patient, you can make out the diagnosis.
Yes, absolutely. We have got quite a few number of patients who presented with back pain and with some possibility. If you take the history, there is some possibility of movement developing over last few months or like that. So you send to neurology, you will get that there is something movement disorder.
Yes, sir.
Frozen shoulder.
Frozen shoulder.
So okay.
Thank you, sir.
So we are concluding this session.